Thank you so much for joining us today. This is the monthly Circle of Life presentation. A little housekeeping beforehand. First of all, our vision statement. We envision an informed community open to honest conversations about life and death, one in which we inspire each other to live life fully while acknowledging the inevitability of death, and where choices for end-of-life care are effectively communicated, documented, respected, and honored. And along with that, we present lots of quality of life presentations, as well as other informative pieces to help us live our best lives. Little housekeeping, we'll take questions and comments in the chat. There may be some interaction requests from our presenter, and we certainly ask that you type in your responses, and I will unmute myself at that time if she can't read them and present at the same time, because sometimes the computer screens go a little wonky there. Also, if you do not want your face on the recorded video presentation, please close out your camera, and please keep yourself muted so we don't hear things during the recording that would interfere with our presenter. The Circle of Life Coalition is always looking for volunteers also to help us promote our mission for education. So anyone who would like to partner and or has educational ideas, please contact us through the website on the contact form. Today, we are very pleased to have Ms. Marcia Goodman Hinnershitz, who is the Director of Planning and Development for the Council on Chemical Abuse, the coordinating agency for drug and alcohol services in Berks County. She obtained her Master's of Social Work at Temple University and has been responsible for the coordination of community coalitions and task force on pertinent addiction issues, including maternal issues, tobacco prevention, and most recently, the Berks County Opioid Coalition. Thank you very much, Marcia. I'm so glad you're here.
Okay, and thank you very much. And it's been a real journey in our work with the Council on Chemical Abuse. And right now, we're probably faced with the most overwhelming health crisis from the time that I've worked at the agency, which has been close to 30 years now, looking at the opioid epidemic. So what I'd like to do is present an overview of what's happening in Berks County, but also provide an opportunity for a discussion because you're all partners in the solution. So I'm going to be sharing a PowerPoint with you, and then after the PowerPoint, we can be having more discussion. So just wait a second with the technology here. Gotten a lot better with this over the years. So you can all see the screen with the PowerPoint? Okay, great. So just a little bit about the Council on Chemical Abuse. Our acronym is COCA, which I've always found interesting because that also means cocaine in Spanish, but we try to be sensitive to the idea that people like to use acronyms. We always want to educate them that we're all about taking leadership and assisting in the prevention of substance use and promoting treatment and recovery from addiction. So for today's presentation, we're going to be focusing on, first of all, understanding the opioid epidemic, the trends that we're seeing, and then tying it into understanding substance use disorders. You'll find throughout my presentation, I really don't use the word addiction, definitely don't use the word addict, because we're moving to language that looks at substance use disorders as a chronic disease. We're going to be looking at stigma and some of the myths, and then what hope and help there is available in our communities as well as across the state. So the first thing is to understand the epidemic. And it's interesting, as we're moving out of a pandemic with COVID, that throughout the whole time before COVID and continuing on is that we've had a significant epidemic with opioids. So the first thing, and I know probably this is a review, a lot of folks probably know this information, but I think it's just good for us to be on the same page. So that lovely graphic I have there is the opioid poppy plant. And it's where all the opioids come from, either man-made or synthetic. And I always like to use a visual. If you all can remember the movie The Wizard of Oz back in the day, and there's a scene in The Wizard of Oz where Dorothy and her friends are seeing the land of Oz, but they go through a poppy field and they all fall asleep. And that's a significant representation of that's what happens when you're under the influence of opioids. It does cause you to fall asleep. It's going to sedate you. Okay. And it's a natural substance extracted from the poppy, and it binds to the opioid receptors in the brain. And so we've had opioid in many forms throughout the centuries. If you look at some of the historical things, there was the opioid wars. There was continues to be the availability of opioids from China. It's one of their major exports. So we know it's been around for a long time. So it comes in a lot of different forms. Heroin's probably the one we're most familiar with. Morphine's been around for centuries, and then codeine. There's also synthetics, the fentanyl, the carfentanil, and then the drug that's used to treat opioid use disorders, methadone. We also have the opioids in synthetic forms, and of course the prescription pain relievers, the Vicodin, the oxycodone, and the Percocet. A little bit about the prescriptions. We know that it was one of the marketing strategies of our pharmaceutical industries, and I do mention Purdue Pharma to call them out because they're under litigation on this, that produced a lot of these prescription painkillers like the oxycodone, the Percocet, and using that as a way of helping physicians to be able to treat pain. And the way that they promoted this was they worked together with education, taking the lead on establishing the identification of pain as one of the indicators that you look at when you're doing a health screen. So anyone remember being asked that, what level of pain you are on a score of 0 to 5? Okay. And so if you were experiencing pain, the automatic solution is let's prescribe some kind of medication, and it was the opioid drugs. What wasn't said at that point, when this was being promoted, that these drugs are highly addictive, okay, and that if you stop using them, you can go through very serious withdrawal. So people weren't given all the information. There was a lot of denial that these drugs were addictive. So as a result, a whole population became addicted to the opioids and felt that they needed to take them if they were going to address pain. So we have opioids that are both prescriptions and illegal. Prescriptions are safe if taken as directed for a short period of time. That's not what happens with a lot of folks. They end up taking them for long periods of time. I don't want to take away from the fact that they are many times medicinally needed. For instance, if you're in a lot of pain from cancer, you have fentanyl patches, there is appropriate uses for them. But we have to recognize they can be dangerous and deadly. They can lead to addiction, and there is a high risk for overdose. We also know that, of course, there's a lot of illegal distribution of your opioid drugs. The ingredients are unknown, so they're manufactured with not any type of quality control. They're mixed with other substances, and the composition changes. So when you're looking at the illegal drugs, you're not going to have any warning labels or telling you what the dosage should be. And what's very concerning at this point in time is with the synthetic opioids. They're 100 times stronger than what was out there with the heroin. They're laced in other drugs. So you'll find that fentanyl can be found in your marijuana that's purchased illegally, in your cocaine, and your methamphetamine. It's all laced with fentanyl. And we do know now our heroin supply is almost 100% fentanyl. It's not the heroin that was available back even a couple years ago. So what we see was with most of our overdose deaths, there's presence of fentanyl. Excuse me, I just need to take a short drink. So the Council on Chemical Abuse and our responsibility for providing support for people that don't have insurance and need public funding, we track what their primary drug of use is. And for decades, it had always been alcohol. That was the primary drug. But now in the last couple of years, 40% of our admissions, the primary drug is either heroin or opioids. 40%, with 25% being alcohol, and then followed by marijuana. We'll always see some changes in this, but we're seeing a consistent trend with heroin being what people are reporting as their drug. So let's just look at some of the data. In Pennsylvania, in 2021, there was about 5,300 overdose deaths, which is a 3% increase, continuing to rise. So in Pennsylvania, you can say in every 2 hours, one person has died of an overdose. In Berks County, we are seeing a continued increase, starting from 2016, and this is from our Berks County coroner. We saw an increase. The only drop we saw, interestingly enough, was in 2018, and then it continues to increase. And if you see this, 2021, we had 144 overdose deaths, which is a 6% increase. And we know that 2022, even though we don't have the final data in from the coroner's office, they're still getting some of the finalized testing done. It's going to be even higher. So you see in this graph, the continued increase again. The decrease occurred at the same time across the state as it did in Berks County. But what's most important to know is that opioids were related to 76% of the overdose deaths, and 70% of them contain fentanyl. We also like to be able to get a deeper dive into who might be most affected. So we know that 60% of the deaths are in the age range of 25 to 54. Now, some people want to think it's younger people, teenagers. They tend to use other drugs, marijuana, nicotine through vaping, but it's the population, the working age people between 25 and 54 that we're seeing the greatest number. 70% are male, and about 56% of them died at home, meaning that they were using the drug at home and that's where they overdosed. And our trends across Pennsylvania, and also you'll see in Berks County, that Black Pennsylvanians have a higher rate of fatal overdoses than white. So when we're looking at our strategies, we have to look at where we see the pockets of concern. This is a chart that was put together by our SOS coalition. I know there's a lot of data in here, but if you start looking at the trends, you're able to see that there's an increase with the Black population as well as the Hispanic. So we know that we need to be culturally appropriate when we're reaching out and looking at who our key partners can be that can reach these populations. So locally, there's been an increase, especially with the Black and Latino. So with all that data, and I didn't want to go with what I call analysis paralysis, giving you too much data, but I just think you need to have a framework of what it looks like. We want to understand a little bit about substance use disorders. So addiction, substance use disorders, is a brain disease. And what does that mean? A lot of times when we look at drugs, we look at how it affects us as far as our coordination. It can affect people with long-term use of alcohol, with cirrhosis of the liver. There's all different kinds of medical effects, but primarily the drug goes into the brain. It's a chronic disease where the brain feels it's being rewarded because of the use. So it stimulates our limbic system of the brain, and it makes the brain desire to have the drug. So the brain is motivated. I want to have that effect. The memory of the brain saying, this feels good, I need to have this effect to feel normal. And so it affects all the related circuitry. So rather than our primary instincts are for food and survival, the brain is hijacked and the primary motivation is to have the drug. And once that person gets onto that track, it becomes more important for them to have the drug than anything else in their lives. So there's a persistent use of the substance despite substantial harm. Again, the brain's hijacked and the voluntary drug-taking behavior becomes compulsive. So if you look at a drug like a prescription opioid, the reason the person initially took it was for the pain, but now the use of that drug becomes primary. So everything else in their life is hijacked around that. So they may then want to be able to manufacture that pain because the drug's saying to them, you need that. And that's how they feel they need to survive. So they're not going to be very happy with anyone that's saying to them, you're not supposed to be using. So there's a perception that people can control their use. If you look at comparing it to other chronic diseases, if you have schizophrenia, you're not expecting the person that's schizophrenic to control their hallucinations. You know that's something that's beyond their control. A person with Parkinson's disease cannot control the effects of that disease. A person with depression can't. So we can't expect people with substance use disorders to voluntarily control. We need to provide them the help and support so they can get on a road to recovery. What also is concerning is that we have over 20 million Americans suffering from addiction, but 75% of them do not receive treatment. And that's very much unlike other diseases, where we may have treatment for chronic disease like diabetes, heart disease. With substance use disorder, there's a lot of barriers and people don't receive treatment. So we know one of the main barriers to people receiving treatment is the stigma associated with the disease. That people that have substance use disorders are looked down upon by society. And that makes them less motivated to get help because they don't want to be able to be perceived as being bad people. Stigma is a set of negative beliefs about a group of people that society holds. And it causes discrimination and exclusions, and it's based on a lot of assumptions, preconceived beliefs and generalizations. So it causes discrimination, and it really delays the acknowledgement of the disease, and it inhibits prevention, treatment, and care, and also a lot of research. So I want to give you an example of where I saw, and I've seen it so much, stigma playing itself out. A very valued coworker that I knew from working in the city, an extraordinary, brilliant man, but he had a long-term alcohol use disorder. He started alcohol use at the age of 15. Unfortunately, he's since passed. But people kept saying, oh, he's so productive, he's so intelligent. Oh, but he's drinking just because he's having problems with his partner. They weren't recognizing the severity of the disease. And unfortunately, by the time it was recognized, he was in late stages where his liver had been compromised. And you could see the indicators of it. He was jaundiced looking. People weren't looking at that. They were just looking at, oh, he's a nice person and he lost his partner. So that's why he was drinking. And it was unfortunate. I got involved in intervening and connecting him with it first was detoxification. He then, because of the severity of his alcoholism, he needed to be inpatient in the hospital. He never did survive because all of his major organs had been so compromised by his drinking of alcohol, and he died probably the age of 48, okay, from the alcoholism. So that just shows you, and if was recognized, but people didn't want to see that in him. And they were trying to deny that it was a problem because they felt like, oh no, he couldn't be an alcoholic. He couldn't have an alcohol use disorder. So we have a lot of words in our vocabulary that describe alcoholics and people with alcohol use disorders that are very stigmatizing. And what I'd like you to do is just take a moment in the chat room to think about some of the words and some of the perceptions that come to mind when you're looking at a person that may be using alcohol or other drugs. We know words like alcoholic and addict. A drug abuser is called a drunk or a junkie. I'm looking in the chat room to see whether anything's popping up here. Okay.
While we're waiting for folks to maybe throw in words that they've heard or perceptions that they have for folks who have a substance use disorder, there was a question related to something you presented just a little bit ago. Why would the brain have opioid receptors? That's a little deeper dive, but is there any insight on why some folks receive Percocet or Oxy and don't really have the uncontrollable urge to consume it beyond script directives?
Yeah, different people, just like we have predisposition for other kinds of chronic diseases, like some of us have more predisposition to develop diabetes. Okay, our brain chemistries are all slightly different. Okay, so some of us will have the receptors and will not be able to use the drug. Anyone that's prescribing, a physician knows that they're going to be looking at certain indicators before they make a decision to prescribe a drug. So certain people are more high risk. The one thing you might want to look at is your family history, but a lot of times families don't talk about their problems with using substances, so that's sometimes hard to identify. So you have to be very careful when making a decision to prescribe an opioid, how that person might be reacting to it, and very closely monitoring their interaction with the drug.
Right. So for opioid receptors, that part of the question, opioid receptors don't just respond to a narcotic.
Right.
They help to regulate the body's response to hormones, neurotransmitters, and also are involved in taste, vision. So it's not just that. I hope that answered your question.
Yeah. And it's a very complex question too, because
yeah.
Our brain chemistry is not like, this is not something that we can give brain chemistry 101 in this presentation, okay? So I don't want to avoid the question. It's a very good one. But what we have to do is treat each person individually to be able to look at how they might be impacted by the drug. You need to be able to do a real good history and understand, and again, monitor how they're reacting. So some of the words that were put in the chat room that may be describing a person with a substance use disorder, homelessness, loser. Okay, there was another one up there. Lazy. Yeah, not very positive ways of looking at a person. So if a person has that perception about themselves, they're not going to be motivated to seek help. One of the other things when we talk about words to avoid, when we talk about people that are getting a screening for their substance use, and then, for instance, they're getting a urine screen. Well, it's a dirty urine. That's not very well. It's either positive or negative as far as whether the drug is present. So we have to, even within the professional field, there's a lot of negative stigmatizing language that's used. So we talk about a person with an addiction. That's a positive way. Person with unhealthy or harmful use, a positive or negative drug screen. What we want to be able to be very clear with our messaging is that addiction shouldn't define a person. Support helps, stigma hurts. So this is our message for the Berks County Stigma Reduction Campaign. Just want to go over a couple of different myths versus reality. First of all, there's a belief, well, it's their own choice to use. Addiction isn't a choice. You don't choose to become addiction. It's a medical condition and needs attention the same way we treat other chronic diseases. A person should only be revived from Narcan a few times and then left to die. And believe me, I hear this even with some of our EMS folks. They'll believe that, okay, we tried a couple times, they're not responding, they're not recognizing they have a problem. The reality is we don't neglect care for those with other diseases that require repeated medical attention. For instance, if you're diabetic, you're not going to take the person off of their diabetes medication because they still continue to have, high AICs. I know I didn't get that right, but you keep giving them treatment. We have to keep addiction treated. Narcan just enables people to stop using. Narcan gets you to breathe again. And we'll talk about this in a few minutes. It enables people to continue living and gives them the opportunity to get into treatment and recovery. Medication-assisted treatment isn't real recovery. First of all, just let you know what medication-assisted treatment is. For people with opioid use disorders, in order to help them with their recovery, they're also provided medications such as Suboxone, methadone, buprenorphine. They're medications that are designed to affect how the brain is receiving the drug. But a lot of people in recovery may believe that you shouldn't use another drug to help you with recovery. You should just go drug-free. Really, everyone's pathway to recovery is different. So combining medications and behavior modification therapy has been shown superior to just talk therapy alone. People do need the drugs to recover. Another idea, she's already been in treatment 4 times. Don't you think it's not working? Just like with any treatment with chronic disease, people need to be given opportunities and may enter treatment multiple times. It doesn't mean it's not working. As with other chronic diseases, an individual with addiction may suffer a relapse and need to return for treatment. And just a little bit about that, if you look at people's brain scans when they're first entering into treatment, you can see the impact of the drug on the brain. And as they slowly are recovering, the brain scans can show less of an impact, but it takes years for that to happen. So people in very early recovery in the first couple months, even the first couple years, may tend to relapse and just need the support to get back into their path to recovery. If someone has a stable job and family life, they can't be suffering from addiction. Sort of goes back to the person I was speaking of. Anyone can be vulnerable to addiction. Many people hide the severity of their illness and don't get help because of stigma and shame. If drinking or using drugs causes any kind of conflict, it's worth seeking support. Can anyone, and I'm just going to ask you verbally to contribute, can anyone think of any other myths about substance use disorder or addiction? You want to go off mute if you have anything you'd like to contribute? Probably when we leave this training, you might start thinking of things that you're aware of. It's important if you're hearing any of those myths to be able to have the information that you feel confident to be able to say to the person, no, addiction is a chronic disease of the brain, okay, and it requires a long term for recovery. So there is help and there is hope. The first thing is that we have to be ready and prepared to address overdoses. Just like if a person needs CPR, we need to be prepared with that first aid to be able to keep that person alive. So when we see an overdose, what happens is a person has a toxic amount of drug or a combination of drugs that overwhelms the body. Now, you can overdose from other drugs besides opioids. You can overdose from alcohol. You're going to become unconscious and you need to have emergency treatment for that. For opioids, what we see as the warning signs is the person is pale, clammy, their body goes limp, they turn blue, they may be vomiting, the breathing stops, they're unconscious, their heart slows down, pinpoint after heart stops, they're going to be dying, okay? And they're unresponsive to pain. What's important is that you're prepared to be able to respond to the person that may be suffering from an overdose. And it's through a drug called naloxone that the person can be revived. What you see on the screen here is the nasal naloxone that we distributed through the Council on Chemical Abuse. It's available for anyone to have in their home. It's not only for people that are medical practitioners. We believe that anyone who's been prescribed an opioid drug or is in recovery, or if their family member knows the family member is in recovery, they need to have Narcan or naloxone in their home. Our kits come with the 2 doses, gloves. We have a mouthpiece to protect the person. And we have an educational insert that gives you information on how to use Narcan. I think I'm going to put this up in front of my face here. I guess you probably can't see that, can you? This is what our kits look like. And so on the outside of our kit are the instructions on how to use. Again, we make those distributed at no cost to anyone in the community. You just need to contact us at cocoburks.org, and we will provide you with at least 1 kit, any that you feel you can help distribute to the community. We appreciate that. The Narcan gets that person to start breathing again. What's really a little bit concerning is with the amount of fentanyl out there, you will sometimes need more than 1 or 2 doses to get that person revived, may even be more than that. So before administering Narcan, we always say to the person, call 911 immediately. Get that ambulance on the way. That ambulance is really a mobile emergency care unit that will be able to, the EMS folks will be able to get that person stabilized. But you then want to be administering the Narcan. We give training for that online. Again, directions are on the kit. Any help you need to be able to use the product. What's important is once the person is in the ambulance and they're taken to the hospital, with Reading Hospital Tower Health, we have what we call the warm handoff program. We have treatment counselors assigned to the emergency rooms. They're qualified to have discussions once the patient is medically stabilized and can arrange for treatment on the spot. The program began in 2015. It's called the WHO program, where there was 24/7 on call. In 2017, we had personnel from the WHO program that were embedded, meaning that they were there at the emergency care unit at Tower Health 24/7. And then Tower Health made a decision under the leadership of Dr. Barbera to expand services to all overdoses, and then moved it on to anyone with a substance use disorder would be referred to the warm handoff program. So it wasn't only people that were overdosing, if there was any indication of a substance. With Penn State Health, we're available on call. They haven't moved to the 24/7 embedded, but the reality is that Tower Health ECU receives most of the people that are experiencing overdoses. So just a little bit of our statistics. In 2022, there were 868 people who received warm handoff. 345 of them were users of either opioids or heroin. 6% of them were overdose survivors. So some of them hadn't actually overdosed, but they were still receiving the service. 73% accepted treatment referral, meaning that they were able to get on a pathway to recovery. And if you look at the number of warm handoffs per month, 82% a month, meaning that 3 occur every day. So we hope that that will help us change the trends for the number of overdoses. It's our really best pathway to recovery. So it's important to connect to treatment. We know that SUD treatment, substance use disorder treatment, reduces drug use and associated healthcare costs. So there's many options to access treatment. What we are showing here is your insurance card, which will show you how to connect with your insurance company, call them, and they will let you know how to access treatment. But for people that don't have private insurance, they can go through our central intake point at the Treatment Access Service Center. They can get help through a hotline number, or there is also a website, which you can find on our Coca-Burke's website, which shows you where the nearest treatment facility is. So it's not hard to get access to treatment. There's a lot of ways to connect. We also want to help people connect with prevention resources. So again, going on our website, cocaburks.org. One of the resources we have is the Response magazine. It's distributed twice a year through our SOS Berks Coalition. Has a lot of good articles on how we're addressing the opioid crisis in Berks County. So you can go on the SOS Berks website to download the response. It's also important to listen to the voices of people in recovery. They can offer the insights, and they're probably the best spokespersons for talking about how there is help and hope and how you can avoid judgment. So what I'd like to do now, I'm going to stop sharing my screen for a second. Before I show the video, I was wondering, any thoughts, any comments, any questions? I would need to check in the chat room.
I just put the link for the free kits on, as well as the general website. I don't see any other questions yet.
Okay, so I'm going to share with you a video from one of our staff persons doing recovery. She'll be sharing her story, and then another story from a person who has a family member in recovery. Let me just.
My name is Yvonne. For 29 years, I have been in recovery. Life, take two.
Am I okay?
I can remember my first use was 2 bottles of wine.
Can you not hear the video?
We can hear it, but it's not running. We just see the 2 YouTube pictures up.
Okay. Let me unshare. I know what is going wrong here.
My name is Yvonne. For 29 years, I have been in recovery. Life, take two.
For some reason, I'm having trouble getting the right screen to share. It was working perfect before.
It was, oops, we even tested it. My apologies, everyone, while we get this straightened out. I don't know if Gary, you have those links up, if you could share Yvonne's story for Marcia.
What I'm trying to do is get my screen. Am I still sharing a screen?
Nope.
Okay.
Hold on one second. I can do the same thing. Hold
Okay.
on. Share screen. And there. Share.
There we go.
Good.
But we can't hear her, Gar. Oh boy. Yeah, I don't know why we can't hear her.
Okay, I think probably what we need to do, because I don't want people to be part of our technical issues. If Gary, you can stop sharing.
Okay.
Okay, what I would just want to do now is just open it up to any thoughts. I actually would like if people wouldn't mind putting their faces on and turning off their videos so I could actually see who I'm talking with. Would that be okay with folks?
Sure, anybody who wants to, and then certainly comment, have some little interactions, share your own stories, see what happens. Hello there.
Hello.
Thank you. So I just wanted to, with the presentation, was there anything that you heard today that was like a little different, new piece of information, a little bit of an aha moment, things that maybe you didn't quite agree with?
Well, for me, I actually enjoyed your changes in the perception of the disease of alcoholism and drug addiction. You basically are taking away words that have been used in the past and redefining what that is all about. And it's a disease of the brain. It's a disease, a legitimate disease that much like diabetes, you have it. And, you know, if it's left untreated, it's so subtle and so sneaky, and it makes you believe you're less than. It makes you believe that, you know, given society's viewpoints over the decades about that, that you are a bad person and you can't tell anyone about this. You must keep it quiet. And I believe that's why so many people die of this addiction, you know, now on a daily basis, because you can't tell anyone. You have to keep it quiet, particularly people in business who have established a reputation in the community. They can never find out. I know of several people in positions in positions, you know, of running companies, etc., who absolutely cannot let anyone know, or they would be exiled, you know, or so they thought. So I love how you changed that, and I think that's a move for progress for the better. So that's where I'm at.
Yeah, I agree. There's a bigger stigma to addiction to substance use disorder than there is to someone, a friend of yours, who comes to tell you, I just finished radiation treatments, or I was diagnosed with Parkinson's disease,
Oh yeah.
because there's embarrassment with any disease diagnoses. There's the feelings that you have internalized that your friends are going to, or people in general, are going to pity you with any disease diagnosis. But add to substance use disorder just the judgment that's gone along for decades. It just doesn't help. And not to mention, disease can financially ruin people, can ruin your career, but addiction unchecked, not can, but will. So it's just really, it's tough stuff.
As an addict and an alcoholic, you tell yourself stories that aren't true, and you continue to justify it. And particularly if you're successful, people will sign on to that. Well, look how successful he is. Little do they know that he's eating pain pills on a daily basis, and tolerance is building. Before you know it, he's eating 80 Vicodin or Tylenol, and however he's getting it. Basically, the bottom line for an addict or alcoholic is, I will get my supply because that is my lover. Family comes second, business comes second, third. It just becomes all about that. So, it is what it is.
And I think we're making a journey towards changing attitudes. The fact that we now have first responders that 5 years ago wouldn't even think of themselves, and I'm talking about police officers and our EMS, that wouldn't even think of administering naloxone or Narcan, and felt very negative about people that they found that was their own fault. Now we have them reaching out and helping and actually being spokespersons for their peers. So that's what our approach is that the more people that have the message can pass it on to others and do it in a way that's accepting and respectful. And by the way, when there was a mention of cancer, back in the day, cancer had a lot of stigma attached to it.
For sure.
It wasn't until there was a lot of people that were in recovery from cancer that came together as spokespersons and were able to talk about their process of recovery and where they were with the disease, that disease became less stigmatized.
Right.
Okay. So it's a journey that we make with a lot of illnesses that we just need to be able to reinforce with recovery, because people won't recover unless they know there's support and acceptance for them.
Right. But when I ran the Greater Reading Mental Health Alliance for 7 years, we saw so much of that. People coming in. In fact, we would see it and they would deny it, and then we could eventually get it out of them and get them into treatment. But the bottom line was, it was so hard to get them to open up unless there were obvious signs and symptoms sitting in front of us. And then it became a question of their going into the cover up and trying to convince you that, hey, no, I'm not, but yet you have the obvious symptoms. Because I have found that the disease of alcoholism is basically the most obvious symptom of a more in-depth mental health disorder, and we use that to treat it. So anyway, that's been my experience over the years.
Yeah, and there's a lot of tie-ins between the stigma around mental health and substance use, and people will treat their mental health disorders with substances, and then they have what we call co-occurring, and It's for the diagnosis to be such that you can sort of pinpoint what's in existence and then get the best route to treatment. The good news is we know how to treat these diseases. It's a matter of making people feel comfortable about the idea that it's okay to accept the treatment.
Mm-hmm. Yep.
I think what's interesting is you've brought humanity to the addiction, and you've made people realize that this is a a concern for human beings, and we're starting to treat people as human beings, relative to not something that's an outcast of society.
Mhm.
And I just wanted to also ask you whether or not do you have support groups and any kind of mentorship program for those that are going through this?
Okay, so the one gift that we have in recovery is that the need for support has been a long time tradition with the treatment of starting with alcohol use disorders and moving on. So the fact that we have the AA fellowships that had a strong foundation and is international now, people understand about the 12 steps and the support there, including the mentorship, is through what you call a sponsor when you get into the program. But we also know that there's many pathways to recovery. So some people may not use the pathway of AA or Narcotics Anonymous. And so we have a variety of different pathways that people can choose what's most comfortable for them and have that be accepted. So the Council on Chemical Abuse has established a recovery center, the RISE Center, which is down at 9th and Oley Streets, where people come and have meetings, whatever their pathway might be, and spreads that out to the community, whatever's most comfortable. So I think what's good is that groups like AA and Celebrate Life and such have sort of set a standard and a norm that it's okay to be able to find your own journey and your own pathway. And that's been what I think our best strength is. We know that people recover better if they have a support group available to them.
Right.
There's some other things I wanted to share with you that are important in how you can be a partner. So one of the things we know is that if people have easy access and availability to the drug, they're more likely to continue to use, or it may put a family member, a child at risk. So we want to make sure that we have mechanisms to dispose of our unused medications. And I see Dan Kimball here, who's been one of our real partners in our medication disposal events. And I want to thank you, Dan, for all the work you do through the Medical Society. But the Council on Chemical Abuse is wanting to make sure that you know how to dispose of your unused medication. So I just wanted to put out to the group, I'm sure all of you have unused medications. Hopefully you don't keep them in your medicine cabinet. How do you dispose of them?
Take them to the pharmacy.
Yeah,
Yeah, that's what I run a home care company, and you cannot believe the amount of medication that's in a senior's medicine cabinet in the kitchen. We find that routinely, old prescriptions of opiates and everything else. So it's a huge thing for seniors to get that concept. It's a huge
okay,
thing.
so one of the things that we do to make it easy now, first of all, you can go to one of the events where there's disposal of medications. You can go to your police department, and they all have medication disposal boxes, thanks to the DA. But what we've done with the Council on Chemical Use to bring it easier into the home is we have what we call medication disposal bags. And you can go on our website, cocoburks.org, and order them. Okay, they are basically have a charcoal substance in them. You put in the medication, you add warm water, it dissolves, and then you can throw it away in the trash. Now, for people that are in hospice care that may have a large amount of medication that needs to be disposed of, we have larger bags that can actually fit in the fentanyl strips. Okay, and we want all the hospices to be able to have those to give to their clients, so that when they're making plans after the person's deceased, that they have an immediate way of getting rid of the medications. Okay, so I can't tell you the quantity I have in our office. I just saw, I think, Dr. Kimball's spouse there in the picture. Hi, Eve. He's a buddy of mine. So we want to make sure that you contact us and we can deliver to you large quantities of medication disposal bags. We just want to make sure that people are able to get those medications out there, because we're finding that there's a lot of children, young people that are taking the meds. They tend to want to be able to use them at party events. They call them farm parties, where they combine a whole lot of medication in a bowl and just take whatever's there. And that's where you have the problem with overdoses. We're also, by the way, finding another problem emerging with the marijuana dispensaries, that adults are having them at home and the kids are getting into them and using them and overdosing from the medical marijuana. So that's starting to be a real problem. The other piece that we're doing now, and it's a very new initiative, is we know with the fentanyl being out there that there's a lot of people at very high risk of fentanyl overdoses. And so we're trying to be where the drug user is and being in their place and helping them to reduce the harm by giving them access to fentanyl test strips so they can test their drug to find out whether there's fentanyl in it. This is very new. It's just been legalized in Pennsylvania in January, but we want to make sure that people have a way of testing their drug supply, and hopefully then if they find fentanyl, they won't use and dispose of it. So just let you know some of the other new things that we're doing. Okay, and thank you, Deborah, for putting those in the link to our different places. And again, just go on our website.
Yeah, it's all there. It's all there.
So I'm going to be just asking you before we end the presentation for a call for action. I'm just going to go around and ask you one thing you might think that you might want to do differently now based on what you've heard to be able to help us with the opioid epidemic. And I want to start with Deborah so that we can,
Okay, give other people time to think.
Yeah.
My brain thinks, you know what? I need to, one of my daughters is part of the Young Women's, Berks County Young Women's Association, and they actually do a yearly presentation to young folks of how to be to women. It's the Young Women. I can't think of the right name. She's going to kill me. But anyway, to empower them to be active within the community, to take different actions. They had Senator Schwenk there last weekend, and there was exercises about, legislation and how you can help. And I think I'm going to ask them to invite the Council on Chemical Abuse to some of their events, just so that you're present. There's a movie March 22nd at the Goggle Works related to racism, I think it is, but you should have a table there, so I think I'm going to suggest that to her and her team.
Thank you. Okay, anyone want to go next? Things they might do, an action step they might take?
Well, I don't know that I have anything new, Marcia. We do have, in conjunction with you and the DJ's office, we have a turn-in drug event every year out at the Reading Phillies Stadium where people can bring their drugs. So that's an option that happens once a year, and we try to make a case for people to go through their medicine cabinet and take any medications that have expired or they're not using and bring them out to the stadium for turn-in, and then the DA's office does a good job of getting rid of all that for us.
Yeah, and thank you for your work. By the way, if you want to look at quantity, the last statistics I was looking at through the DA's office, they have disposed of over 5 tons of unused medications. That just shows you how much is out there that people are taking responsibility to get rid of, but that's enormous.
Thank you, Marcia.
Thank you, Dan. Anyone else, any action steps they might see themselves taking?
Well, certainly for me, it's passing along this information to folks within my congregation, et cetera. But also thank you for the explanation about that new way of getting rid of drugs with that charcoal in it and the water and things. I know some people were concerned about if they drop them off, do they take their label and personal information off, and well, what really happens to it, that kind of thing. So that may be another way they may be more confident in disposing of it more completely and close to home in a way.
Yeah, we know all people can't get out. By the way, when you do take them to dispose of them, you do black out all your personal information from the prescription.
Mhm.
Okay, thank you very much.
Yeah, thank you.
Anyone else? Okay, just sort of think that what I'll ask you to do when you leave the presentation, just write down one action step you can take. Okay, because everything is meaningful as making a difference. The last thing I'm going to ask you to do is just for some feedback. So I'm going to, and I know I'm going to be successful this time for sharing my screen. Oh no, I can't share the screen. Oh,
I'm going
well.
to throw a poll up here real quick
Okay.
that has some questions on it that people can fill out. And it's just very, very basic. Yeah, so let me just launch that real quick. But I want to take this opportunity to thank everybody for attending. Please share it. Please encourage people to view on our YouTube channel and the circleoflifecoalition.org. Next month, we will have somebody from the Humanities Gift Registry to discuss body donation, which actually has come up for whatever reason. In the past couple of weeks, I've had people ask me, how do I donate my body? So this will be a very timely topic for April. And Marcia, thank you so much. We're so grateful that you came to do this presentation, educate us all.
And I'll send you the QR code if you want to send it out to the people that attended them, okay?
I can definitely do that.
Thank you, Marcia.
Yes, thank you.
Thank you.
Have a great day.